Hi, I'm Brian Jacobson, one of the Associate Editors for Gastrointestinal Endoscopy, and I'm here with Dr. Ian Gralnek, who's from the Rambam Medical Center in Haifa, Israel. We're going to be talking about his manuscript, Is Routine Second Look Endoscopy Effective After Endoscopic Hemostasis in Acute Peptic Ulcer Bleeding? Now, this was a meta-analysis. First, Dr. Gralnek, can you tell us what is a second look endoscopy and why would one do it?
So second look endoscopy is generally done in upper GI bleeding. Today, generally, if you are clinical indications. So there is if it's clinical indications or if it's sort of scheduled and routine. So routine would mean that you've done the endoscopy, you may or may not have performed endoscopic hemostasis, but then within a defined period of time afterwards, generally within about 24 hours, sometimes less, sometimes more, you routinely go back, re-perform an upper endoscopy to look and see is there ongoing high-risk stigmata, and we're talking about peptic ulcer bleeding here by and large. Is there ongoing high-risk stigmata, and does it need to be treated in an attempt to try and improve patient outcomes?
So, what did you find in the meta analysis?
Well, we found basically that there may be a role for doing routine repeat upper endoscopy in selected patients. Okay. Now, in the era of high-dose IV PPIs, it really may not be necessary. This meta-analysis, we looked at almost 600 citations. We were looking for randomized controlled trials that were looking to evaluate routine second look endoscopy versus not having that, and looking at specifically primary outcome was rebleeding, but we also looked at surgery and mortality. Now, of those 577 citations, we actually identified 8 that met our inclusion and exclusion criteria. They were randomized trials. 4 were fully published manuscripts. 4 were published abstracts. It encompassed almost 1,000 patients within those 8 studies that looked at this. So the answer here is that although our findings suggest that routine second look endoscopy may be important to reduce rebleeding, if you really dissect the data and look at these studies, there was only one of these studies that was done within the era of high-dose IV PPIs. Now, if you throw that study out, okay, there is, or when you look at that, rather, if you look at that specific study, there's no difference in terms of the need for second look endoscopy. So in other words, in the era of high-dose IV PPIs, we do not believe that routinely we should be doing second look endoscopy. There's some risk that's associated with second look endoscopy. There's risk in terms of potentially in patients who may have comorbidities and are unstable. There's risk of potential anesthesia, etc. Now, if patients for whatever reason are not getting high-dose IV PPIs, or in potential patients who have a very high-risk lesion, I'm talking in the subpopulation of active bleeding at the time of the initial index endoscopy, maybe we should be going back and doing a repeat second look endoscopy. But for really all comers, it really should be based on if they have clinical symptoms of rebleeding that we should go back and do that second look endoscopy.
Yeah, and I think that's helpful to put it in that context. I did want to ask you, there were some of the abstracts that you used had not appeared subsequently as a full published manuscript, and some were as old as 5 years.
Right.
Does that affect the reliability of your findings, or how should we take that into consideration?
In general, what we wanted to be is more inclusive. So we didn't want to just throw those out. We wanted to look at all the data. We did not look at it broken down by with and without abstracts. We included all of the literature that was available. And we did search back almost 20 years. So we wanted to be more inclusive than exclusive.
Okay. And do you end up contacting some of the abstract authors?
We did not in this situation need to contact the authors. The data that we were looking for and what we were extracting was there in full in the manuscript.
Okay, great. Do you think if we were to, let's say, do an endoscopy in someone where there was bleeding, it seemed like there was, those big fresh red clots up in the fundus, but you didn't see active ongoing bleeding, but just that red big clot. Would that be something, if the patient seems stable the next 24 hours on an IV PPI, do you think it's reasonable to just observe them?
That's a good question. I will say that today First of all, in the era of potential use of a promotility agent,
Such as erythromycin in the United States.
exactly, IV erythromycin, IV metoclopramide. There has been a meta-analysis that has shown that it improves our visualization at the time of index endoscopy if you give that to the patient 30 to 60 minutes before your endoscopy. So you may be able to cut down on that. But let's say what you're saying, that there's a big red clot there, and you're really not able to fully observe. In my opinion, that's really an incomplete endoscopy because we have not fully visualized where there may where there may be the source. It's covered, and oftentimes there can be active ongoing bleeding underneath what you're able to see. Now, in those types of specific situations, generally, we will take the endoscope out, continue to resuscitate the patient, provide blood, whatever needs to be done, put them on high-dose IV PPI if they're not already on that, and then plan within probably the next 8 to 12 hours to go back, give them a promotility agent at that point also to try and facilitate gastric emptying, go back within 8 to 12 hours and redo the upper endoscopy. Because that's really that's an incomplete exam. You've not fully examined the entire upper GI tract.
Right, and you wouldn't know, as you make the assumption it's a bleeding ulcer, but it could be a duofoil lesion or even neoplasia that you would not want to miss.
Absolutely,
Okay.
absolutely.
Well, thank you very much for sharing your information with us today. We appreciate it.
Thank you, it's been a pleasure.